Live. A very warm welcome to all. I'm Dr. Shyam Akku, Head of Medical for Emerging Markets for Hetero. And thank you for joining us today for the session on updates in the management of prostate cancer, organized by Hetero in cooperation with Philippine Society of Medical Oncology. It's a great honor to have Dr. Karim Fizazi as the guest speaker, Dr. Josephine Tolentino from Philippines as the chairperson, and Dr. Arthur Gregory and Dr. Agus Rizal as speakers from Philippines and Indonesia, respectively. Let me take this opportunity to introduce our chairperson for today's session, Dr. Josephine Tolentino. Dr. Josephine Tolentino, she is the Section Chief of Medical Oncology, Department of Medicine, the Medical City, Philippines. She is the Treasurer and Governing Council Head of the Scientific Committee of Philippine Society of Medical Oncology. She is a member of the Medical Oncology Fellowship Training Committee of the Medical City. She is the Consultant Director of Chemotherapy Unit, and she is the Visiting Lecturer and Clinical Faculty of the Medical Interns of Ateneo School of Medicine and Public Health. She had her fellowship training in medical oncology at St. Luke's Medical Center and had a preceptorship course in head and neck at the National Cancer Center Hospital East, Kashiwa, Japan, clinical observership at MD Anderson Cancer Center, Houston, Texas. I'd like to invite Dr. Josephine Tolentino to begin today's session.
Thank you very much for that nice introduction, Dr. Shyam Akku. And firstly, I would like to thank Hetero for inviting me to be part of this event. I'd like also to welcome all the attendees who are watching right now. And just for the information of my colleagues in the Philippines, this webinar is being shown also to other Southeast Asian countries and other countries also like Tanzania, Zimbabwe, Nigeria, Nepal, among others. I am delighted and honored to share the virtual stage with our esteemed speakers, and I would like to introduce to you our first speaker. Professor Karim Fizazi. He is a medical oncologist, but he is also very popular among urologists. He is the head of the Department of Cancer Medicine at the Institut Gustave Roussy, Villejuif, France, and a professor of oncology at the University of Paris. Dr. Fizazi has been involved in many phase 1, 2, and 3 clinical trials as a national or global coordinating investigator. These include GETUB or GETUB 12 and 13 and numerous industry-sponsored clinical trials, including the denosumab versus zoledronic acid pivotal study, the TUX 700 post-docetaxel, and the cabazitaxel OGX-011 large phase C trials in castrate-resistant prostate cancer, and the abiraterone latitude phase 3 trial in patients with hormone-naive metastatic prostate cancer. Professor Fizazi is a pioneer in the creation of the Prostate Cancer Consortium in Europe. He also coordinated the PEACE-1 phase 3 trial testing the role of abiraterone acetate and of radiotherapy directed to the prostate in patients with newly diagnosed metastatic prostate cancer treated with ADT, as well as the PEACE-2 phase 3 trial testing cabazitaxel and pelvic lymph node irradiation in patients with high-risk localized prostate cancer treated with ADT radiotherapy. So ladies and gentlemen, let us all welcome and learn from Professor Fizazi.
Thank you very, very much, Josephine, for these kind words of introduction, really. So I'm delighted to be here with you today. So good morning, good afternoon, good evening, depending on where you are on the planet. This should be really, really fun. Let me share my screen. I guess it will be easier for you to follow my talk. And let me put this in full screen. All right, I think you should see it now. Let me know otherwise. And really, this presentation is about the current and evolving landscape for men with advanced prostate cancer, including hormone sensitive, but also castration resistant disease. And by the way, I apologize, we have ongoing work here at the hospital, so you might hear some background noise. I really apologize for that. It's been like that for days and days, I have to say. So let me dig into my presentation with my disclosures, including participations to boards and talks for various companies. And just to simplify your learning, if you want to see just one slide, this is a slide summarizing the current landscape for men with advanced prostate cancer. At least, of course, if you are fortunate enough to be in a country or a hospital where everything is available, which almost doesn't exist on this planet, unfortunately. But still, scientifically speaking, you will see that in various settings of the disease, you will see in blue the drugs that were available, say, 10 years ago, plus or minus, including androgen deprivation therapy, docetaxel, and zolinic acid. And then you will see now in red all the drugs which were shown to be active in various settings in the last decade. And you can just figure out in just one site that the amount of progresses for this disease has been really tremendous. Again, ranging from hormone-sensitive disease to castration-resistant disease, and even patients who have exhausted basically everything. But if ever, again, we're fortunate enough to have access to these treatments, and unfortunately cost is an issue at many places, there are different basically philosophies or strategies that you might discuss for your patient. First one is use those active treatments as soon as you can. Second strategy, sequence treatment A, then B, then C, then D, etc., etc. Strategy number 3, combine those treatments to better target the heterogeneity of the disease. And finally, strategy number 4, personalize your treatment and try to give that gentleman this given treatment, while this other gentleman will have different treatments, not necessarily only based on clinical parameters, as we all do, of course, but also based on the biology of the disease. So let me try to review for you where we currently stand with regards to all these 4 strategies for these patients as I'm speaking. And let's start with earlier treatment. What do we have? I will follow the natural history of the disease, starting with high-risk localized disease. And since a year, we have great news for patients. For the first time, indeed, in basically more than 2 decades, we have a tremendous progress for men with apparently localized disease, but with poor parameters, including high glycemic score, high PSA, T3, T4 disease, nodal disease nearby the prostate. For these men, we all know that androgen deprivation combined with radiation is mostly the standard of care and does better as compared to just one therapy, radiation or ADT alone. This is well established for 2 decades. But for the first time a year ago, we saw that adding abiraterone acetate and prednisone for just 2 years in this population of men tremendously postponed the onset of PSA progression, but also metastasis, and most importantly, death. As you can see here, overall survival is significantly and of course very clinically meaningfully improved, with approximately 40% reduction in the risk of death when abiraterone is being added on top of ADT and radiation. Meaning that most men who are now diagnosed with localized disease will basically not die from the disease, at least within the first decade after they are diagnosed with the disease. And I think this is a fantastic achievement. So, and this is based on just 2 years of treatment. So I think big improvement for these men. Second situation, where we also saw, I think, very important improvement. This is what I tend to call more and more early castration-resistant disease. So patients with rising PSA while he's castrated and no detectable disease based on conventional imaging, and you might see here and there some few spots if you do a PSMA PET, if you're fortunate enough to have access to this new technology. But that doesn't really change the question. The man remains the same, and his disease remains the same. And we now have level 1 evidence coming from 3 randomized trials, Spartan, Prosper, and Aramis, that early intervention is needed in these men, especially, of course, if they have a rapidly rising PSA. Not only metastasis is significantly postponed, but also death is postponed in these men if you're intervening early. Third situation, patients with metastatic hormone-sensitive disease, mostly de novo, a man you're diagnosing today with a prostate cancer and today with his metastasis. Since, say, 2015, we know that docetaxel prevents the onset of progression and death, with approximately 20% reduction in the risk of death when docetaxel is being used in these men. This is the first meta-analysis based on the 4 randomized trials that establish this reality in the mid-2000s. But more recently, we had updated analysis from the 2 most optimistic phase 3 trials, Charted and Stampede. And actually, it seems that the benefit is lower than initially reported in these 2 randomized trials, with 28% reduction in the risk of death in Charted, not 40% as initially reported, and 19% in Stampede docetaxel. So yes, docetaxel improves outcome, but men are still dying. And as you can see from the shape of the curves with this kind of banana phenomenon, the curves tend to merge with time. Probably because docetaxel is not given chronically, because we don't know how to do that. This is just too toxic. And with time, cancer progresses. 2 years later,
Dr. Fizazi, sorry to interrupt. Could you please put your slides in full screen mode? We're seeing 2 slides.
I think they are at least on my screen. I can try again.
Yeah.
Is that in full screen now?
No, we're still seeing 2.
Okay, let me try again, maybe to stop sharing, and I'll try to go back and share again, because sometimes with Zoom it happens. Because on my screen it shows full screen.
Full screen, yeah.
Let me try again. Maybe if I do the PowerPoint instead of the full screen, this may work better. Let's see. Is that better now?
Still we are seeing.
Still not in full screen. Okay, let me try last time. Otherwise,
Okay.
I'm afraid it's a Zoom issue.
Okay. Yeah.
Let's see. Does it work now?
Yeah, we're still seeing 1 slide. Yeah.
I'm so sorry. Because on mine it's really on full screen. So
okay.
I don't know.
Can you see some buttons on top of the screen? Three buttons which are there.
Yeah.
Are they visible on top? Not that one. On the top. If you scroll your mouse towards the top, above latitude and Stampede, the titles. Okay. Do you see some? Yeah. In the center, there's 1 button. If you can click that.
In the center, which new sharing, you mean?
Okay, so I think those buttons are not visible to you.
Okay. Yeah. Which button is that?
Yeah. You just take your mouse a little bit. Yeah, that one. Just click that.
Okay.
Yeah, duplicate. Just try one of those. Yeah. This is better. Yeah.
Good. Congrats.
Okay.
Yeah. Thank you so much.
Yeah.
Right, and I apologize for that. So 2 years later, starting in 2017, we saw the first readouts from randomized trials testing 2nd-generation hormonal agents with abiraterone coming first. And this is Latitude and Stampede abiraterone, both showing overall survival and actually very stable data, very robust data, and very reproducible data. By the way, you can see the shape of the curves, they're totally similar. 2 years later, we saw confirmation from these two trials with the other second generation hormonal agents, namely enzalutamide and apalutamide. Again, what's impressive to me is the consistency of the data. They're almost always the same, all these trials, showing this very important benefit to all the patients. But really the next question was really, should we use chemotherapy or should we use a second generation agent? Or maybe should we actually use both? Because these agents do not work the same. They don't necessarily have the same toxicity profile. And we know we can combine. We have multiple phase 1-2 combination trials showing that it's doable. But does it work? And that's really the question we've been asking in the PEACE-1 academic phase 3 trial, which enrolled only patients with metastatic castration-sensitive disease. All these men had de novo disease. And we basically asked two questions. Number one, should we intensify further the systemic treatment with abiraterone on top of ADT docetaxel? We have the answer to this question. I will show you this in a second. Second question, should we also irradiate the primary in a context of intensified systemic treatment? For the second question, we need to be patient and see more events before we can run the analysis. Potentially this year, to be honest. We'll see. We're waiting for the updated sweep of the trial. But regarding the question of systemic treatment, as I said, we saw the data a year ago, and they're good. As you can see here on the screen, if you're adding abiraterone on top of ADT plus docetaxel, the time to progression will be tremendously improved from a median of approximately 2 years to more than 4 years and a half for patients receiving the triplet treatment. So you're really providing 2.5 additional years of good life to your patient without cancer progression, which I think is very important. And most importantly, of course, overall survival is also significantly improved with a 25% reduction in the risk of death in men receiving 3 drugs instead of 2. If I put this into context and try to review what we have achieved in the last decade or so, in the first part, the first half of 2010 years, we're still using ADT alone, and the likelihood for survival for men with de novo and high volume disease, so those with multiple bone metastasis or visceral metastasis, was unfortunately less than 3 years. Very consistent from one trial to another trial, by the way. When the docetaxel was added, overall survival was improved, as I just showed you, to approximately 43 months, let's say, as a median. When abiraterone was added, overall survival was also improved to, say, 50 months plus. But now, if you're adding both docetaxel and abiraterone, your patient may live more than 5 years, again, instead of less than 3 years, just 5 or 8 years ago when we were using ADT alone. And again, this is really focusing on men with the worst disease, de novo, and high volume. So I think it's really very important improvement for the patients. The great thing from last year, 2022, is that this data is now confirmed. You will see again to the left-hand side the PEACE-1 data with abiraterone, but we now have confirmation that 3 drugs is better if you're using darolutamide or enzalutamide as the third drug, in the center with Arasens, and to the right-hand side with Enzamet. And you see again the consistency of the data. The curves are almost the same, regardless of the agent you're using. 3 drugs better than 2. So I think the current standard for now should be for men with de novo and high volume disease who are fit for chemotherapy. We should, I think, propose them a triplet treatment, ADT, docetaxel, and the drug you like, abiraterone, darolutamide, or enzalutamide, or of course the drug you have access to. I fully recognize, of course, that some men are just not fit for chemotherapy, so they should be proposed ADT and a second-generation hormonal agent. Now, for patients with low volume, of course, you need a longer follow-up because these men live longer before you can tell whether X or Y can help them. And I think for now, it's fair to say that castration plus a second-generation hormonal agent plus radiation directed to the primary, which also improves survival, should be discussed with these men. We may actually go more and more toward a triplet systemic treatment, at least on a 1-by-1 basis, especially for young men who are fit. If sometimes they have 2 to 3 bone metastases and sometimes a large one, these men actually behave pretty much like the high volume men. So I think that for these men, we should start discussing triplet systemic treatment, and more data will come very soon to support what I'm saying. For patients with a relapse, it's much more difficult to provide guidance. Of course, these patients are rarer. We tend to use castration probably earlier, before we develop metastasis, for rising PSA, for example, so that they were absent or rare in the phase 3 trials I just showed you. I think it's reasonable to consider ADT plus a second-generation hormonal agent, at least in patients without too much cardiovascular disease risk. And I fully recognize that some patients are just too old or too frail to tolerate intensification, and for these men, by default, ADT alone remains the standard of care. We need more data, and actually this is exactly what we're trying to do in the P6 platform of phase 3 trial. Instead of just randomizing A versus B, we are actually trying to test different questions in different subgroups of men. For example, the subgroup of men with oligometastatic disease, for those ones, we are randomizing the role of radiation therapy directed to metastatic disease, and we have already enrolled more than 200 men in this trial. In patients who are vulnerable, hard to intensify, we are randomizing the role of darolutamide, which is quite safe. And we are just about to start 2 phase 3 trials in men according to whether they are good or poor responders by PSA at 6 months after the start of their systemic treatments. For good responders, we will try to test de-escalation with perhaps less intensification. And for poor responders, we will try to randomize the role of additional intensification with lutetium PSMA in these men. And this last trial is about to start very soon. So this was about early treatments. And as you can see, I think it's fair to say it's been a win. In the last 5 years or so, we have a lot of good reason to consider early treatments for most men with advanced prostate cancer. But what about sequential treatment? Should we use A after B after C, etc., etc.? What do we have? We do it in the clinic, of course, but what evidence is supporting that? And the first question is really, if you have been already using castration, should we still use old generation hormonal manipulation, dexamethasone, estrogens, old generation AR inhibitors, bicalutamide, etc.? Or should we go immediately to second generation hormonal agents? We have two randomized trials testing this hypothesis. I'm showing just one for the sake of time, but they show the same data. And this is a trial testing second generation AR targeting with enzalutamide versus old generation bicalutamide. And as you can see, enzalutamide does a much better job. What was shown here in terms of the primary endpoint of the trial, which is progression-free survival, was also demonstrated in terms of quality of life, which I think is very important for patients. And my recommendation, sorry, I had a flu recently. I apologize. So what we're showing here is, I think, a clear guidance to try to avoid using too much of the old generation hormonal agents we've been using in the past. But the very important question, of course, is more about men who have exhausted either abiraterone or enzalutamide. How best to treat these men? And this is, of course, a very tricky question. The slide is actually showing you the bad news. And the bad news is that we should probably not sequence these agents, abiraterone and enzalutamide. It doesn't really work. If you're using ABI after enza, only 5% of men will benefit, very few. If you're using enza after ABI, it's slightly better, approximately 20%, but it's not fantastic and typically not lasting very long. So this is really something we should try to avoid as best as we can. Now, this slide is showing you, I think, the good news. And the good news is that taxane remain active in many men who have exhausted abiraterone or enzalutamide. This comes from the COO302 phase 3 trials of abiraterone. These men were treated afterwards, after progression, with the Taxane. And as you can see, most men derive benefit with a PSA response rate of almost 50% and a time to progression of almost 8 months. Not that different as compared to what you would expect from the Taxane in men naive from abiraterone or enzalutamide, which indicates that there is no or minimal cross-resistance between taxane and second generation AR targeting. And actually, this was subsequently demonstrated with CARD, with cabazitaxel. And CARD was really a very pragmatic randomized trial, which was asking us a question. In a man who had exhausted at least one AR drug and one taxane, should we go for the second AR drug or for the second taxane? So ABI or enza, depending on what the patient has received, versus cabazitaxel. Clear answer, cabazitaxel wins, whatever the comparator and whatever drugs was used first, ABI or enza, cabazitaxel does a better job, and this was true in terms of progression-free survival, but most importantly true also in terms of overall survival, with a reduction of 36% in the risk of death. So it remains very important to use taxane in this disease. What about combination? I showed you that combination clearly works in hormone-sensitive disease, and we should use it with a taxane and an AR drug. And this is also probably true with radiation therapy directed to the primary. But what about the situations of metastatic castration-resistant disease? And here it's much more tricky. We have much less evidence to support combination as I'm speaking. For example, we had the ERA 223 trials randomizing radium 223
in men receiving abiraterone. Not only the trial was negative, with no benefit from the combination arm, but actually it appeared that the combination arm was harming patients, or at least some of them, in terms of fracture, which in retrospect makes sense, given that if you are using ADT and abiraterone, the risk of osteoporosis for your patient is quite strong. And of course, if you're irradiating with radium a frail bone, you might actually end up with a fracture. And this is pretty much what happened in this trial. So based on this data, a second trial, which was ongoing, P3, decided to amend the protocol to make bone protecting agents, mostly denosumab or zoledonic acid, mandatory for all new patients who were entered in the trial and who were to be randomized to receive enzalutamide plus or minus radium. And actually, we don't know, at least yet, whether the combination of the two, enza radium, does better than enza. But what we know is what the denosumab or zoledonic acid does in these men. And you will see here the incidence of fractures in men before and after the amendment, making denosumab mandatory. In blue is the curve of fracture for men who were treated with enzalutamide and radium without denosumab. And it's terrible. 50% of them actually develop a fracture by 2 years' time. Disaster. In green, you will see the same fracture incidence for men receiving enzalutamide alone without denosumab. And that's not good. Approximately 25% of these men also develop a fracture by 2 years' time. Now, to the bottom of this figure, you will see in black and in red these same patients receiving enza plus or minus radium, but with a bone protecting agent, denosumab or zoledonic acid, and you'll see that this prevents the onset of fracture in almost all patients, which I think clinically for a practice is a very important message. We should use bone protecting agents in men with bone metastasis and castration-resistant disease. This is very important, and I think this has been underused in the last decade, which is a big mistake for the patients. Almost, I guess, every time we use enzalutamide, and probably, of course, abiraterone or apalutamide, darolutamide, in men with castration-resistant disease, we should consider very seriously using in parallel a bone-protecting agent. And this is even more true if you're looking at the worst skeletal-related events, which is spinal cord compression. Almost 10% of these patients will develop a spinal cord compression if we're not using a bone-protecting agent. Zoledonic acid decreases the incidence down to 4% approximately, and denosumab down to 2.3%, if you will. So even if it's not absolute protection, this is really becoming very rare if you're using a bone-protecting agent, and this is another reason to consider using this agent, I think. Last part of this talk, can we personalize treatment, and can we invent new agents even more active? And here, obviously, the biology is helping us with very important insight from genomic studies performed in the last decade again, showing that patients failing taxane and second-generation hormonal agents such as abiraterone or enzalutamide, but what? The main driver of the disease remains the androgen receptor pathway, which means that most men who still die from the disease have an ongoing machinery of the androgen receptor. It's still working. And this means that if we are able to invent a super abiraterone or super enzalutamide, we may be able to prevent more death. Now, in parallel to that, in some men, some subgroups, PTEN is lost, and due to that, the PI3 kinase pathway is activated, and this is potentially a target for treatment. DNA repair also appears as a potential very important target for treatment, and I'll come back to that in a second. And there are others potential pathways or targets for treatments. But let me focus first on the androgen receptor. This is the normal simplified, of course, biology. This is a wild type androgen receptor, and this is the natural hormone, androgen, DHT or testosterone or another one. And of course, when the hormone binds to the receptor becomes active, it goes into the nucleus and binds to the DNA and acts as a transcription factor. Now, in men failing abiraterone or enzalutamide, in approximately a fourth of them, the AR is mutated. So it's not longer this first version, but now this one. This is, for example, the L702H mutation, which is one of the most frequent we see. In these cases, the androgen do not activate anymore this version of the receptor, but corticosteroids can do that. And in another version of a mutated AR, the 878 mutation, progesterone can actually do the job. And please remember that progesterone is present in males, while testosterone is also present in females, of course, just a question of concentrations. So in these men, we should probably not target only androgens anymore. It's not going to work. We should target corticosteroids, progesterone, and actually, to be honest, other hormones in other cases. We've been trying to do that with a drug called ODM208, which targets the key enzyme just downstream the cholesterol. It's called CYP11, and this prevents the making of all precursors that can make corticosteroid, mineralosteroids, and sexual hormones. So you're totally blocking all hormones, and of course, for a patient to survive, you're supplementing them with glucocorticoid and mineralocorticoid, the way we do that in Addison disease, for example. And it actually works. All these men had already exhausted at least one second-generation AR targeted drug, abiraterone or enzalutamide, and often the two. And all of them had also exhausted at least one taxane and often two. And you will see that the response rate in all comers is approximately a third. And if you're focusing on men with mutation of the androgen receptor, almost all patients derive a benefit with a 68% PSA 50 response rate, as opposed to only 8% response rate in men without mutation. So this was achieved in the phase 1 context, and we did a phase 2 expansion cohort in men with androgen receptor mutations. And as you can see, this data was completely confirmed with a 53% PSA 50 response rate in these men with androgen receptor mutations. So not only we have a drug that works, but we probably have a biomarker that can help us select who are patients candidate to benefit. And this is just simply looking at the mutations. Hopefully phase 3 will start soon. A second, as I explained briefly, a second pathway is the PI3 kinase AKT pathway, which is activated in parallel to the androgen receptor in men with PTEN loss, which occurs in approximately 20% of cases. A randomized phase 2 trial beautifully suggested that for these men with PTEN loss, combining an AKT inhibitor with abiraterone does a better job as compared to abiraterone alone, but the benefit is actually only for men with P10 loss. To the right-hand side, you see P10 non-loss do not derive benefit. And the same data was shown with two dosing, 200 milligrams or 400 milligrams. P10 loss benefit, no P10 loss, no benefit. Based on this data, a randomized phase 3 trial was designed, and we saw the first readouts of the trial. It's positive, and the p-value is good. But to be honest, it's not as positive as we were hoping it to be. Why is that? One reason is perhaps that P10 loss was assessed by immunohistochemistry, not sequencing, and this might not be the best way to look at this. The second reason is that the combination might be just too toxic, and it's chronic toxicity with GI toxicity, rash, transaminase increase, and of course, if you cannot give the second drug, you will not show much benefit as compared to abiraterone alone. So I think this is a lesson for ongoing trials. We should make sure we can mitigate the additional toxicity we are providing to patients. Otherwise, these phase 3 trials will end up with just comparing A versus A and not A versus A plus B. So again, food for thought for further development. Another very important weakness of the disease is DNA repair. Approximately 10% of men have germline DNA repair alterations, mostly BRCA2 in approximately 6 to 7%, and somatic alterations are also present in approximately 10% of these men. Whatever the exact numbers, it means that a significant minority of men have a potential weakness in their cancer that we can try to better target for better outcomes of other patients. And we now have level 1 evidence that indeed using a PARP inhibitor can improve outcome in men failing abiraterone or enzalutamide and often failing taxane. Not only progression-free survival is improved, but also overall survival is improved with olaparib in the PROfound phase 3 trial. And this is now standard of care, at least in countries which have approved the drug. What we don't really know, though, is whether we should use PARP inhibitors only for patients with BRCA alterations. For these men, I think the data are crystal clear, and it's a yes answer. But whether we should also consider using a PARP inhibitor in a man who is about to start a second-generation AR pathway inhibitor for castration-resistant disease. And indeed, in the PROPEL subgroup analysis, which reported first readouts last year, combining abiraterone and olaparib in non-BRCA patients limited actually the risk of progression of death with a reduction of 24% in the risk, which was a first. And this was really striking because at the same time, another trial, Magnitude, didn't show this data. So whether this was an artifact or a true finding was and remains still currently debated. The issue is that if this benefit is true, it also comes with significant toxicity. GI fatigue, GI toxicity, fatigue, anemia are often seen with olaparib, and actually maybe more often when combined with abiraterone, as you can see here. And very importantly, an excess in pulmonary embolism was also observed, 7% versus 2%. So we really need to have strong efficacy to be convinced, I guess. And this is really the question we're asking ourselves. Should we consider using or not a PARP inhibitor in non-BRCA men? First question, is Propel just an artifact, a false positive? And indeed, biomarker assessment was done post-randomization. It was not a stratification factor. And there are some potential weaknesses with the way the biomarker was assessed in the trial. Fortunately enough, a third randomized trial will read out very soon. The TALAPRO-2 data will be released in less than a month from now at the ASCO GU Congress. So we will see whether Propel was just an artifact or a true finding. Now, if it's true, the medical question now is it worth it? Because in Propel, currently we have radiographic progression-free survival improvement being suggested, as I just showed you, but no quality of life improvement for patients. We don't know whether their symptoms is improved or not. Skeletal mutated events, we don't really know. Overall survival, we don't know. So we need the data, because of course this is important in a context where toxicity is significantly improved, or I mean, not improved actually, worsened. Not even speaking about the cost of this combination. And if this finding is a true finding, we have now a scientific question, which is what is biological explanation? Is really AR targeting in parallel to a PARP inhibitor generating BRCA-ness? I honestly don't know. Are the available tests just missing BRCA deletion? It could well be. Or are PARP inhibitors doing something else, which we don't know, besides PARP inhibition? And if so, it would be, of course, very important to figuring this out. So you see, more data to come, more debate, and hopefully more scientific knowledge. Finally, PSMA is a potentially very important target. To be honest, it's a well-known target. We know it for decades, but until recently, we were not able to use it as a target. This is a transmembrane protein, which is overexpressed by prostate cancer, and mostly by advanced aggressive prostate cancer. The good news is that it's rarely expressed by normal cells, with the important exception of salivary gland cells, and to a lower degree by the kidneys. So VISION was the first phase 3 trial to address whether PSMA targeting can help these patients. All of them had already received a second generation AR targeting drug, abiraterone or enzalutamide. All of them had also exhausted at least one taxane, docetaxel, and actually many of them had exhausted 2 taxane or 2 AR drugs, abiraterone and enzalutamide. They were randomized to receive whatever we could, give to these patients, with the exceptions of chemo or radium, just because you cannot combine with lutetium PSMA, or the same, plus lutetium PSMA, given every 6 weeks for at least 4 cycles, and 2 additional cycles could be given in benefiting patients. As you probably all know, overall survival is clearly improved in the trial, with approximately a 40% reduction in the risk of death. And this was also true for a radiographic progression-free survival. So this is becoming more and more standard of care for many patients. And of course, we're waiting for new trials testing lutetium PSMA before patients have received chemotherapy for castration-resistant disease. We should see data from the PSMA-4 trial and the SPLASH trial, hopefully this year. So you see, we have more and more examples of biomarker-triggered efficacy in metastatic disease. BRCA predicts for PARP inhibitors. MSI-high predicts for PD-1 inhibitors. For sake of time, I didn't even show you the data. PSMA positive cancer predict for efficacy of PSMA mutation. And more may come. PTEN loss and AKT inhibitors, AR mutations and ligand inhibitors, CDK12 biallelic mutations, and PD-1 inhibitors. In conclusion, I think that early treatment is better, generally speaking, in many settings of a disease. Sequential treatments remains routinely used, but this is perhaps not the smartest way to treat this disease. We do it mostly by default. The clear cross-resistance between abiraterone and enzalutamide, unfortunately, and likely this also applies to apalutamide and darolutamide. But the good news is that taxane are not or mildly cross-resistant with abiraterone and enzalutamide, so that we may combine and we may sequence. And we're just starting to arrive finally to an eve of biomarker-driven medicine. This is true for PARP inhibition, and this is also true for PSMA mutation, and probably more is coming. With this, I thank you very much for your attention, and I'm of course delighted to hear colleagues and to take questions. And I leave the floor to Josephine. Thank you very much.
Thank you very much, Professor Fizazi. That was really wow. This was very extensive. I remember before 2010, there was nothing but docetaxel.
Absolutely. And that was so hard to treat this poor man. I agree.
Yeah. And to the audience, we will take your questions after the three speakers have presented. So you can put your questions in the Q&A box while we are waiting for Dr. Louis. So Dr. Louis is a colleague of mine. I admire him for his looks and brain. He's a friend, and he's a medical oncologist in the Philippines. He is the vice chief for training at Metro Davao Medical Research Center in the Philippines. He is a consultant at the Southern Philippines Medical Center, Davao Doctors Hospital, and San Pedro Hospital. He completed his master's in clinical medicine, major in medical oncology, and doctor of medicine from the University of the Philippines College of Medicine. He had his fellowship training in medical oncology at the Philippine General Hospital and fellowship in medical oncology, thoracic and gastrointestinal oncology at Cross Cancer Institute, University of Alberta, Canada. He is a principal investigator of many clinical trials and has various publications in his name. So, ladies and gentlemen, we open the floor for Dr. Louis.
Thank you, Dr. Tolentino, for that actually very kind introduction. Just allow me to share my screen here. So again, good day, good morning, good afternoon, and good evening to everyone watching. So I understand this lecture is being broadcasted all over the world. We have delegates from Africa, Southeast Asia, and of course, the Philippines. First of all, I'd like to say that I'm really honored to do this part, to share the virtual stage with an expert, Professor Fizazi, and of course with our colleagues from Indonesia, Dr. Hamid, and our session chair, Dr. Tolentino. I'd like also to say my thank you to Hetero Pharma for organizing this event. This is truly a very helpful CME for us medical oncologists. So at this point, I'll be discussing some treatment perspectives from the Philippines. So just a quick background, I am a medical oncologist practicing in the south of the Philippines. We do see, we're mostly community oncologists, so we see a variety of tumor types. So mostly in my talk, I'll probably be focusing mostly on metastatic prostate cancer. That's mostly the prostate cancers that we see. And really what I just really like to, this will be a very short lecture here, but a very short presentation here. But what I'd really like to just show is that, what's really happening on the ground. We know there are excellent data. I think prostate cancer is one cancer that has evolved so much, as what Dr. Tolentino mentioned earlier. When I was in fellowship, it was really just docetaxel. And I remembered one of my professors in University of the Philippines, after the CHARTED trial was presented, he said, like, we have a new drug, docetaxel, for prostate cancer. But over the past years, this has really evolved. Over time, we've seen better treatment available. So for tonight, in my presentation, I'll be briefly touching some overview of cancer care in the Philippines, some of my medical oncologist's perspective in metastatic prostate cancer in terms of diagnosis, imaging and workup, and of course, the treatment options available. The availability and access to drugs for prostate cancer, and some availability of generic preparations. And I'll just summarize in the last two slides. So this I got from GloboCan, and this is a quick picture of cancer in the Philippines. So if we look at the Philippines here in the picture on the left, for our colleagues in Southeast Asia and India and Africa. If you look at the Philippines, the geography is that this is made up of multiple islands, and that gives us a difficulty, of course, in logistics. We do have different cancer centers, but of course, as a developing nation, there are some challenges that we meet. And if you look at our population, we're a small country, but we have a decent over 109 million Filipinos living in this island country. And this is from GloboCan 2020 in terms of number of new cancer cases. It's over 150,000 in the year 2020 alone. And again, GloboCan did not look at the national registry because we still do not have that yet, but it looked at major registries in the Philippines. And if you look at the number of deaths, it's over 92,000 patients who passed on because of cancer. And if you look at the number of prevalent cases at the 5-year rate, it's around 350,000. So if we look at the number of new cases in 2020, looking at both sexes, male and female, across all ages, the number one still is breast. This is followed by lung, closely followed by colon and rectum, then liver, as we are a Hep B endemic country. And of course, the fifth here is prostate cancer. But if we look at just the male population, lung cancer remains to be number one, followed by colon rectum, but prostate here is now in the number 3. And this is in 2020. This is from recent data. I'd like to show this slide. This is from basically cancer care in the Philippines. I borrowed some of these from the publication of a good friend and a colleague, Dr. Garcia. This is a blog published in cancer.net. It talked about cancer in the Philippines. So in this blog, Dr. Meredith Garcia mentioned that cancer is the second leading cause of death among Filipinos. And the most common cancers, as we saw in GloboCan, was breast, lung, colon, rectum, liver, and on the 5th is prostate cancer for men. In general, and unfortunately for a country like ours, it is still not uncommon. So we still see them. We still see patients with advanced stages of cancer. And this is really the reasons are multifactorial. We know there is low health literacy and high cost of diagnosis and treatment. And what's a reality here in the Philippines is that majority of patients pay cancer-related healthcare costs out of pocket. And the government is also trying to do its best to improve access to cancer care. Over the past 5 years, we've seen the passage of 2 laws that are very important for the healthcare of Filipinos. That's the Universal Healthcare Act, which aims to have healthcare for every Filipino, and the National Integrated Cancer Control Act. And I guess both of these laws, our society, the Philippine Society of Medical Oncology, the gallant men and women behind this society, are actively participating to craft better programs for our Filipino cancer patient. So this is a publication recently published by colleagues in radiation oncology, gyne oncology, and medical oncology here. One of the authors here is Dr. Ting. Here, basically, it shows the geographic distribution of cancer care providers in the Philippines. And here, if you're going back to the map for our colleagues who are not from the Philippines, here we see that the island nation on the left, we see that the majority of the medical oncologists are really located in major cities in the Philippines. So that's in Metro Manila, Metro Cebu in the middle, and Metro Davao in the south, where I am based. But we also see some areas where there are very light-colored blue patches here in this map on the left. And these are really places where there are hardly any medical oncologists. And on the right, we have radiation oncologists, again, very specific, very reliant on the facility, that they need to have a radiation treatment facility available. And again, not all patients would have access to radiation. So in terms of prostate cancer, in terms of diagnosis, a majority of our patients, at least from what I see here in Davao, is that in the south of the Philippines, is that majority of patients see urology first. And if you look at in the metastatic prostate cancer setting, still in the past, and I think in somewhat true at present, is that these are mostly managed by urologists. But again, one of our thrust in the society is for the promotion of multidisciplinary team, the MDT management. Here we've seen an improvement over time, over the past years. There's an improvement of MDT across different cancer centers in the Philippines, and more people are now involved. We, as medical oncologists, we get to see a bit more prostate cancer cases than before. And when we talk about workup, again, biopsy, of course, our urology colleagues would do it. If it's a prostate biopsy, our surgeon's colleague would probably do the metastatic site biopsy. One of the main challenges, say in our setting, is that when we do our metastatic workup, we do have access to standard imaging like CT scans and bone scans, occasionally MRIs, but there are very few centers in the Philippines who would have access to PSMA PET scans. So even in some centers in the outskirts, in the provinces, where chest radiographs and just ultrasounds are the best that they could have. So this slide, I think this is clearly explained by Professor Fizazi earlier about the landscape of metastatic castrate-sensitive prostate cancer. And again, here on the left, this is the charted trial, the docetaxel plus ADT. Again, Dr. Fizazi made a very good perspective here that, just using docetaxel alone, you'll see the curves overlap like a banana. But if we look at the other trials, looking at the novel hormonal treatments, you have abiraterone, enzalutamide, apalutamide, and we've started to see that curves separate more clearly. And on the rightmost side here, we've probably seen the triplet regimen maybe will be a new standard of care for the fit patients. That's your ADT with docetaxel plus abiraterone or darolutamide. That's what is in the guidelines. That's what the data says. But what are the treatment options we have for our Filipino patients with metastatic prostate cancer? Again, I'll focus on metastatic disease. I'm a medical oncologist. That's mostly what I see. And in the Philippines, we do have several approved medications in our country. I would like to just clarify a little on what we can use in the private setting versus what we can use in the government hospital. So I placed an asterisk here on the drugs that are included in the national formulary. National formulary are basically the list wherein these are the drugs that we can use in a government setup. So in androgen deprivation, the ADTs, we have leuprolide, glycerilin, triptorelin, and degarelix. For cytotoxic chemotherapy, I think with the advent of generic drugs, docetaxel has been readily available. Cabazitaxel has been a little difficult to find in the country, but we do have access to the novel hormonal therapy. Currently, what is FDA approved in the Philippines is abiraterone, enzalutamide, and apalutamide. Abiraterone good news is that this has been recommended by our government to be included by the HTAC in the national formulary. And of course, bone modifying agents, zoledronic acid and denosumab. Zoledronic acid has also been recently recommended to be included in the national formulary. The other novel treatments like pembrolizumab and olaparib are also available. Radiation therapy is something that is very facility dependent. We do have limited number of RT facilities all over the country, and we do have a shortage or the lack of facilities and having to have wait times significantly long, especially like in our city here in Davao. So what about the access to drugs? These drugs are available. Patients under private care, private physicians, they can get anything that is at least FDA approved in our country. But if we look at how the healthcare here in the Philippines is that most of these are out-of-pocket expenses, and these are usually either covered from the family's finances or personal finances or private insurance. And what about those patients in government hospitals? Those are public hospitals where majority of our patients with the population would seek medical care, and they are limited to included drugs in the national formulary. These are drugs that would have government subsidy, and there are some centers, government hospitals, who are not capable of managing malignancies, and referrals have to be made to tertiary hospitals capable of cancer care. And this is really good news over the past months. This is something that, of course, our society as well have been working hard to at least get the inclusion of these new drugs. After long discussion, our very helpful, the Health Technology Assessment Committee now recommends that the government financing of abiraterone in combination with prednisone, and this to be included in the national formulary. Here in this recommendation, they've talked about the benefit, and they even talked about the cost. And that is something that I think with the advent of generic drugs, I think we do have generic abiraterone present already in the country. And again, like most of us clinicians here, my experience with the generic abiraterone is that there's better compliance because of the lower cost of treatment, better access, better compliance. But the HTAC did not recommend enzalutamide, and that is primarily because of the cost. The cost was not justified in enzalutamide, hence this was not recommended. Also, very interesting, after very many years with our people from the society, we've been pushing for this as well, but it was just only in October of 2022 when zoledronic acid is now included in the national formulary. So hopefully our brothers and sisters in government setting would be able to access these drugs. So what about access to special diagnostics? Dr. Fizazi talked about the role of MSI testing, germline BRCA testing, HRR testing. So all of these are available, but they are currently in the private settings. So for MSI, what's good is that this is now done locally in the country, but only in specialized laboratories. So in places like where I practice, we have to send out specimen to get results for microsatellite instability. Germline testing, HRR testing are all send out tests out of the country. So what about treatment for metastatic castrate-sensitive prostate cancer? We still have medical castration, and of course, occasionally patients will choose orchiectomy as there's just a one-time cost to the patient, and rather than medical castration wherein they get repeated every 3 or 6 months. And in terms of combination therapy, I think just because of the access to medications, the cost of treatment, out-of-pocket design of our healthcare, docetaxel, although I know triplet is now has better data than just docetaxel alone, but there's still some preference for this because of the low cost and the availability of this drug. Abiraterone has also been more available today because of generic preparations. There's cost has been cheaper, compliance has been better, and of course apalutamide and enzalutamide. So for castrate-resistant prostate cancer, again, we have these drugs. Docetaxel abiraterone will probably be the only one that is included in the national formulary. So just some last few slides here. Prostate cancer in the Philippines ranks as one of the top 5 malignancies among Filipino men. Cancer care in the Philippines, unfortunately, mostly are still out of pocket for most patients and their families. We do have available cancer facilities, and we're working hard to make this a more accessible and better services for our patients. And they cater to patients seeking treatment at government hospitals. Our government, our society, we have been helping each other to improve cancer care through the laws that have been passed, the Universal Healthcare Act and the National Integrated Cancer Control Act. And as we've shown in the graph, in the diagram with how the specialists are distributed in the country, most specialists are still in urbanized cities like in Manila, Cebu, and Davao. However, there's also some improvement in multidisciplinary team management. There's urologists, medical oncologists, rad-oncs, and hopefully these MDTs would allow us to, as what Dr. Fizazi said, get an earlier treatment, get the best treatment that we have for our patients with prostate cancer. Availability and access to medicine, I've touched on that, private versus government. Still, as of today, docetaxel remains to be the preferred treatment due to cost and availability. And of course, abiraterone, before we only had the innovator, now we have generic preparations, and soon this will be available for majority of our patients as this will be included in the national formulary. So that ends my presentation. Thank you, and I'd like to turn back this virtual stage back to our chair, Dr. Tolentino. Thank you.
Thank you very much, Art. I'm pretty sure the participants can now imagine and relate the kind of healthcare we have. And just like what you have mentioned, prostate cancer in the Philippines is mainly managed by urologists, but I think we are really developing MDT. I also have a special interest with prostate cancer because when I used to work for a company, I was the one who launched abiraterone in the Philippines about a decade ago. So let us now go to the third speaker. He is from Indonesia. And I'd like to welcome Dr. Agus Rizal Ardi Haryandi Hamid. He is from the Department of Urology at Cipto Mangunkusumo Hospital, Universitas Indonesia. He is the Secretary of Urology Study Program at Cipto Mangunkusumo Hospital. He is a member of SIU Innovator Committee. He is a board member of the Asian Urological Surgery Training and Education. He is a national representative of Asian Oncology Society and was a general secretary of Indonesian Urological Association. He has done his fellowship from Marie Curie Research, St. Radboud University, Netherlands. He has also done his fellowship in laparoscopic and robotic urology from Germany and robotic surgery training from World Laparoscopy Hospital in India. He has many Scopus Index publications in his name, and he's an author of many guidelines books. So may I call in Dr. Rizal Ardi.
Can you hear me? Hello?
Yes, we can hear you.
Okay. Thank you very much, Dr. Tolentino, for the very nice introduction. First of all, Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, good evening, and maybe good morning also for the Professor Fizazi. And I would like to say thank you for the committee. Also give me a chance to talk about the treatment perspective, prostate cancer from Indonesia. It's really interesting that I can share maybe how we treat the prostate cancer in Indonesia, and also interesting that we can hear from what is the ideal condition that is already presented by Professor Fizazi, and we can see also the experience from the Philippines that's already presented by Dr. Louis, and might be we have some similarity what happens in Indonesia. So I will share my PowerPoint. So can you already see it? Okay. So for the disclosure, because this is the presentation sponsored by the Hetero, of course, all the material is the indications only for the education. As an outline, I would like to present the epidemiology in prostate cancer in Indonesia, diagnosis and staging prostate cancer in Indonesia, and what is the treatment perspective in Indonesia. As you can see in the geography here, we already know that the Philippines also had many islands. If we compare to Indonesia, Indonesia have bigger area and more islands, and also have more difficulty. As already mentioned by Dr. Louis, logistics is one of the problem, and Indonesia also face that problem because we have many islands and many population spread in all these island. This is interesting picture if we compare Indonesia island to the Europe. I just found out that actually we have more bigger or wider area, but if you see in the Europe, they are already in the land on the same island, so they are logistic maybe much easier compared to us. For example, if he wants to send material or truck from Jakarta or capital city of Indonesia goes to the Papua, it takes maybe more than 1 week, especially if we use the ship, because using a ship is less cheaper than if we use the airplane. So this is also the data from the GloboCan, the recent data. I think we see the same data from Philippines, that the prostate cancer actually is one of the most common, number 5 most common cancer, of course after lung, colorectal, liver, and nasopharyngeal cancer. And we found that maybe almost 14,000 new cases from Indonesia. But if we look the data, I think this is quite old data showing that the patient who come to the clinics is already in the stage 4. Almost 60% that the patient come to us is already advanced. So this is also the one of the burden in Indonesia, because we see more advanced cases compared to the localized cases. And our recent survey data showing likely similar data. I mean, around 50% patients come to the clinics in Indonesia is already in the stage 4 disease. And maybe this is also related to how we diagnose the prostate cancer. We did a survey for the urologists, how they do the biopsy. I think how they found out the prostate cancer, almost 70% patient get diagnosed from the TURP, and the rest just doing the prostate biopsy. This might be the explanation that there is a limitation doing the PSA, and also sometimes the patient don't know, or they don't realize they get the cancer, because if the patient had the problem with urination, they try to relate that maybe this is the aging process, so it is normal, until they come, which already feel pain on the bone, and then after we do the checkup, we found out there's already prostate cancer with the advanced cases. And also here, example that the transrectal ultrasound, we only had less than half of the urologists using in the public or even in the private hospital. So this is one of the reasons why we still get the more advanced cases in Indonesia. And also when we do the diagnosis or staging, this bone scans, I think that's already mentioned, is conventional imaging that we found or we use for the prostate cancer diagnosis staging, that the bone scan distribution is much more in the capital city or even in Jakarta. Luckily, if we use the CT scan, there is still, this already spreading more around in Indonesia, but in some province, there is still lack of a CT scan. And we also found that the MRI, they are more in the most populous island, it means Java. So there are some MRI also already outside the Java, but there are more provinces in Indonesia don't have MRI. And if we look at the PSMA PET scan, the PSMA PET scan is already available since 2019, but it's only in the capital, Jakarta. So there is still limitation that because of the big island, the difficulty to spread the diagnostic machine for the prostate cancer, there is still problems. But luckily, in the last 1 year, that the Ministry of Health had to make a priority. They want to improve the management of cancer, especially also prostate cancer. I think that maybe in the next year this MRI or CT scan distribution data can be different from now. So I hope that this year we can say how many CT scan or MRI distribution in the whole Indonesia. So I think the similar like other prostate cancer management that we classify the patient to localized, locally advanced, and metastatic, and very many options. And our society make our local guideline. I think this guideline also refer to the European guideline and also the NCCN from United States, and also we look at how we can apply this based on the data about the availability of diagnostic or maybe the treatment in Indonesia. This is my, of course, my interest that I'm urologist, that we can do the radical prostatectomy in minimal invasive way, even with laparoscopy or robotic. And if we look at the data for the radiation oncologist here, that the distribution for the radiation oncologist is already more spread also, but in some provinces, there are still no machine for the radiotherapy. But I think it's also one of the plan of the Ministry of Health. I think there will be more distribution of radiotherapy in Indonesia. Now, if you look at how we treat the prostate cancer management, it's already mentioned with the previous speakers that now we, as a standard treatment, we should combine the therapy between the ADT with the other drugs. So we can see many options here that we can give to the patient. Luckily, I think in Indonesia have different way to register the drug, because the company has to register to ask the authority, and then after they get the registration, they can sell to Indonesia. Luckily, that most of the drug is already available here. Some maybe like darolutamide, radium 223, and Ciplosil-T, they're still not available in Indonesia. So actually, in Indonesia, we have more option for the treatment for the prostate cancer. But what is the problem? I think it's already mentioned before. We try to which combination that we should give to the patient. First, we can give the chemotherapy, or we give the novel ADT. Both combination has already showing that from the literature that is already give the improvement. But the problem is the price. If you look at the data, this is the data that we try to do the general analysis, that if we give the chemotherapy, because they have a generic, the price is maybe 1/3 if compared to the combination novel therapy. And interestingly, actually, in Indonesia, maybe in the same like in the other Asian culture, they are really afraid with the chemotherapy toxicity, because if we, for my experience, if I explain which kind of drug you want to get the novel ADT, which orally drug, or you get the chemotherapy, they give you the intravenously, they always ask what is the toxicity. Is it because the chemotherapy is really fearful for our people, so they are really avoid to get the chemotherapy in the first line. But the problem is actually the price. So of course the price can be how to say the question for the patient, because I think similar like as in Philippines, that in Indonesia, that's most of the patient have to pay out of the pocket or maybe the private insurance to get the novel IDT. We have a national universal health coverage. It means that all this drug can be supported by the government. If you look at our national formularium, I think it's similar like in Philippines, that we only get the ADT or conventional ADT like leprolin, acetate, goserelin, and also the anti-androgen pecalitamine. The only one combination that we can get supported by government is only docetaxel. Maybe this is because of docetaxel is already having generic, and also the price is more affordable and can be supported by government. And the other thing is actually we want to is there any drug that have a generic but branded drug, but that drug is cheaper or more affordable compared to the patent drug? Until now, there only one drug that we can be afford is abiraterone acetate. We don't have any other like enzalutamide or generic brand drug. We only get the abiraterone. So according to the experience, after we get this kind of generic brand drug, the patient are more affordable and they are more willing to buy the drug. And it's very nice that I get the presentation from Dr. Louis, that it is really interesting that the Philippines now agree that to put the abiraterone in the national formularium. So I think that's one of the, we try to we try to advocate the government. We need to put this drug, because we have more affordable drug, abiraterone, that maybe we can combine with the IDT. So this is the, because everybody talk about the genetic testing. Actually, we have some laboratory that can do the germline testing, but I think the same, that maybe in the laboratory outside the Java, they just collect the samples and then they send to the Java, or some of the laboratory also send to the other laboratory to do this examination. Yeah, this is also helpful because recent drug like PARP inhibitors that needs the genetic testing, that we can also do this genetic testing to do the personalized treatment in Indonesia. And interestingly, also that our Ministry of Health have already developed that they call the Biomedical Genome Science Initiative. They support the government hospital to do this germline testing or genomic testing. So they already started this year, last year, they developed or they create the laboratory, they support the machine. So I think in this year we can develop more about how the service, we can check the germline testing in Indonesia, so we can give the drug more personalized treatment, especially in the metastatic CRPC. So as take-home message, that I think is similar in Philippines, Indonesia also had the burden of prostate cancer cases, especially advanced cases, is increasing, and limitation of the diagnostic and availability of medicine still major issue. How we treat the prostate cancer in Indonesia, and of course, with the more affordable medication can help prostate cancer patient get the better combination therapy, because we already know that the positive effect of combination therapy to the prognostic of the prostate cancer. So I would like to say thank you to my team, Professor Umbas, Professor Haidir, and Dr. Fahri, of course, also Hetero and Dr. Haikal, Dr. Oliver, and Dr. Jason and Ikrar to help me this slide. So I can give back to the moderator, Dr. Tolentino. Thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Rizal. It is enlightening to know that somehow we have similarities in our healthcare system. And I'd like to call in again Dr. Lui and Dr. Fizazi, and of course, Dr. Rizal. Well, I think we have one question in the Q&A box, but I would like to mention about the MRI because I saw in the slides of Dr. Rizal, focusing on certain areas in his country about the MRI, because I think you were trying to drive the MRI fusion biopsy that I think the urologists love. Okay, I was, muted. I don't know. Anyway, I was saying that the urologists love the MRI fusion biopsy because they can, angulate the needle and really look at the depth. But I think Dr. Fizazi also mentioned about the PSMA PET scan as well as Dr. Rizal. And in that context, I would like to ask two questions for Dr. Rizal. Is PMA PET CT scan already somehow of use for biopsy, directed biopsy using the scan, and is it useful in localized prostate cancer? For Dr. Fizazi, what I would like to ask from him is that the PSMA PET CT scan is quite new, and this was not the test that was used with the drugs that we are using now. So I would like to know how it can affect the integration of the treatment using the PSMA PET. So I would like to start with Dr. Rizal.
Yeah, thank you very much. I think I still have not very much experience with the PSMA PET scan, but in our country that we because of the availability of the PSMA PET scan, we only use the PSMA PET scan after the biopsy or the result of the biopsy is positive. So we use it as the staging modalities. So maybe we don't use before doing the biopsy because we don't know about the data. I think there are some studies now, they start to do the PSMA PET scan before the biopsy, but I think in Indonesia we still use that only for the staging or after biopsy. I think that's my comment. And also the problem is the availability. If we overuse that the PSMA PET scan, I think that's more, how do you say it? It's difficult for the patient who really need it, because the PSMA PET scan, I think for myself, because from my experience, it's much better compared, of course, with conventional, because we can see more clearly about the lymph node metastasis, especially, and sometimes we don't see the bone metastatic in bone scan, but we can see it in the PSMA PET scan.
Do you use the level of PSA to guide you?
Yeah, we don't have any experience, but at least no, we don't use that one. We just, because our prostate cancer patient usually come already PSA more than 4. So we check all with the PSMA PET scan, because as I mentioned, I have not good experience with the one patient that with the bone scan is negative, and I do the radical prostatectomy. I thought there is no metastatic, but the PSA is not going down. And then after the PSMA PET scan, we found out that there is a metastatic in the lymph node, and then of course the one bone lesion metastasis.
Okay, thank you very much. May I now go to Professor Fizazi for his answer?
Sure, thank you, Josephine. So basically, your question was whether the current data that we saw in randomized trial, for example, for metastatic disease, also apply if the PSMA PET found the metastatic deposits, which is really a question we are all asking to ourselves, to be honest, because none of these phase 3 trials was designed and conducted when PSMA PET was available. So we don't know the scientific answer to your question. Now, and this is really a question we're asking ourselves, every multidisciplinary team meeting, of course, here in Europe and I guess really elsewhere. But I mean, to be honest, I think the answer is likely yes. And I'm saying that because having seen the abiraterone data from STAMPEDE localized disease, where we do see enormous benefit from adding abiraterone to ADT radiation, it probably means that some of these men obviously have metastatic disease detectable by the PSMA PET, and you do see benefit in the setting. So I'm quite convinced that basically in any bad situation of prostate cancer, an aggressive prostate cancer, intensification of systemic treatment is needed. And just to support what I'm saying here is that really this is something we've seen in mCRPC, in metastatic castration-sensitive disease, in high-risk localized disease. Probably the only setting where we're missing information is that of biochemical failure post-prostatectomy or radiation. Hopefully the EMBARK trial will tell, and I think we will see the data this year. But again, every trial we've seen in the last decade was a positive one. So I think, but again, this is opinion, because as I said, we don't have level 1 evidence regarding that question, but I really believe that indeed, if PET PSMA shows metastatic dissemination in a man who is a high-risk localized man before the PSMA PET is done, I think that indeed intensification is needed.
Well, now that you have mentioned the word intensification, may I go back to the PEACE-1 trial? And, the triplet therapy, of course, the first thing that we will think of would be the side effects. But of course, we will also consider the kind of outcome that it produced. It has doubled the RPFS, and that is something that is very, valuable to our patients with prostate cancer. So my question is, taking into account the comorbidities, we know that these prostate cancer patients are quite elderly, taking into account their comorbidities. And I know that the docetaxel and abiraterone are used in concurrent fashion. Can we, give them in sequence, like, giving first the docetaxel, finishing up the 4 cycles, and then maintaining them with abiraterone? And at which part also will you introduce radiation therapy?
So regarding the use of docetaxel followed by the abiraterone in metastatic castration-sensitive disease, personally I would not do it for different reasons. One is that the trials showing the benefit were used with the concomitant use of abiraterone and docetaxel in PEACE-1, but actually this is also true in Arasens with darolutamide, and also true with enzalutamide in Enzamet. So, and it could well be that indeed part of the benefit that we see is related to the fact that those drugs were used concomitantly with perhaps stronger anti-cancer efficacy as compared to just a sequence. There might actually be some synergy between abiraterone and docetaxel. So that's a number one good reason for me to do that. Number two is that the excess in toxicity we're seeing is actually modest. If you use abiraterone on top of docetaxel, you will see an excess of 22% hypertension, which honestly is manageable if we do our homework. We just need, just to monitor the blood pressures very seriously and treat. And so it's all a task. It's not a problem of a drug. It's more a problem of a doctor. Okay, so we have to do our homework, and I'm really convinced about that. The second thing we saw was a 6% increase in transaminase increase. And again, we just need to do a lot of homework, look at it, and in case it happens, just stop the abiraterone or dose reduce, recycle, all things that we should know how to do. It's not very difficult, to be honest. And that was it. In piece one, there was no other additional toxicity with adding abiraterone. Now, if your question is about the toxicity of docetaxel, of course, docetaxel has a toxicity. I fully recognize that. We need to be cautious and select adequate patients who are fit enough to receive docetaxel. If you can, I would strongly recommend using GCSF primary prophylaxis. It clearly works. It's not crazy expensive, and I, of course, recognize that in some countries and for some patients, they still represent a financial burden, of course. But if doable, I would strongly recommend doing that. We've seen in France, before GCSF and after GCSF in the setting, clearly it's a different situation. We don't see any more neutropenic fevers. We don't see any more death related to chemotherapy with docetaxel when using GCSF. So if you can, I strongly recommend you to do so. I'm really, really convinced that it's a game changer here.
Well, I agree that with abiraterone, it requires more monitoring. But I think in the Arasens, where darolutamide was the drug experimented on, they are both well tolerated. And I think the advantage of abiraterone is that it's now available in its generic form. That makes it, I think, less expensive to give. So I have here several questions in the Q&A box. So I'd like to read the first one. How frequently do you order the genetic testing? As you rightly said, the cost of oncology is rising, and how best we use the guidelines and help our patients in Asia. I think this is a question for Dr. Lui, because it mentioned about Asian healthcare. So may I ask Dr. Lui on the stage, please?
Yeah. Thank you, Dr. Tolentino. Just a question on how I would do how frequently I'll do genetic testing for my patient. I think that's something I would offer routinely, but I'd probably be pushing it for the younger, the probably that patient subset would more likely harbor a germline mutation. That is in terms of looking for germline, say germline BRCA mutations, family history. I would, however, consider getting the more the NGS part of looking at homologous recombinant repair pathway. I'd probably consider that down later in the lines of treatment. I think this is something that's, at least in the Philippines, is more readily available. We have our specialists, and Dr. Ishka Ke, who does all my genetic counseling for my patients. So I think that's something that we have as a resource person here in our country. So I'd routinely offer, especially for those patients who would likely harbor one. Thank you.
I could see that there are also young medical oncology fellows in training in the audience. So do you think there's still a value to do pedigree, just in case we really do not have that capability?
Yes, of course. Yeah, I think I remembered before, prior to getting genetic testing readily available. I remembered years ago it was just to test like one gene, say just to test your Lynch, or just to test your BRCA, takes over like $4,500 US. I remembered asking that I think 5-6 years ago. Now it's much cheaper. But remember, way back before, we didn't have all this testing, and that's why the term, say at least in pancreatic cancer, we say the term BRCA-ness. And I remember my professor before, she was telling me like, these are patients who smell like BRCA. They smell like one. So I guess pedigree, good history taking, because sometimes you just ask, is there cancer in the family? They say no. But once you start to ask, like, how did your grandfather pass on? I said, oh, he had a mass somewhere, and it wasn't cancer, but there was a mass somewhere. So these are sometimes looking at how healthcare in the Philippines years ago would probably be very different now, how cancer is not easily diagnosed as how it is right now. So I guess good history, physical exam, history taking, pedigree, family history is still very, very important.
Thank you very much. I have a question here directed to Dr. Fizazi. What can you suggest as treatment for an 80-plus-year-old patient who progressed on ADT with cardiac problems like intermittent AF and with failure symptoms?
Yeah, that's one of the biggest challenge we're facing. We have an aging population, more cardiovascular toxicity, comorbidities, and those are really daily challenges we're facing. I think PSMA lutein is emerging as an important treatment for patients failing ADT and an AR drug. We have, the VISION trial showed that this is now standard of care for men who have exhausted docetaxel. I really hope that this year we will see data from PSMA-4 and SPLASH, which is really focusing on men who are not candidates for chemotherapy, either because they're asymptomatic, because they're too old, or because they just don't want sometimes. And we should see this year what exactly PSMA lutein can provide for these men. So stay tuned. Of course, we need to see the data. They need to be released and public. But I think this will probably emerge as a potential important treatment for these men, of course, assuming this is available and financially sustainable or reimbursed. For now, it really remains very challenging. I fully agree. If a man has already exhausted, say, ADT and abiraterone or enzalutamide, if he can be tested and if he's a BRCA alterated man, I think a PARP inhibitor is a reasonable option. This is not very toxic. It has toxicity, but it remains reasonable. And the good thing is, if ever you see toxicity, you can just stop or dose reduce and not make the patient unhappy, let's say. But really, PARP inhibitor clearly works in these men with BRCA alteration. And to be honest, platins actually work. I sometimes use carboplatin at very low doses, can be AUC2, for example, and it does work. So this is something we may consider when a PARP inhibitor is not available or just not sustainable, given that platins are very not expensive.
There is another question here. Any one of you can answer this. Is there any significant difference between a normal PET-CT scan and PSMA scan, as nowadays PET is available in more places and PSMA is not?
I can take this one briefly and hear what colleagues think. I mean, if this colleague is referring to FDG PET, FDG PET is clearly inferior as compared to PSMA PET or choline PET. There is no discussion at all, unfortunately. I'd love to say the opposite, because FDG is available, quite broadly, but unfortunately, clearly PSMA PET or choline PET are much better than FDG. So I'm almost not using FDG PET for prostate cancer, to be honest.
In the interest of time, I will just ask one last question. So, well, we know that we are trying to put the treatment as early as possible because we have seen that it has produced significant change over time. So my question is, for an isolated biochemical recurrence after a local regional therapy, would you initiate the patient on systemic therapy? So
who takes this one? After
probably you.
yeah. This is for patients with biochemical recurrence after prostatectomy or radiation. There is a small subgroup of these men in the STAMPEDE abiraterone trial. The trial is positive as a whole, but we don't really know what these men derive as a benefit from abiraterone. It's likely that they do, honestly, but it's not. It hasn't been selectively, if you will, analyzed in the trial. We are waiting for another trial called EMBARK, and this one should read out very, very soon, I think this year, but I haven't seen the data, so I'm happy to, I'm totally neutral because I don't know what the data are. I think there's just a good chance for this trial to be positive, but of course we need to see the data. So again, even if we don't have a perfect answer today, we should not wait very long before we can tell.
So with that, can I call in Dr. Rizal and Dr. Louis on the stage, please? And maybe they can, mention, a line or two about what they want to give us the last message for this event.
Yeah, I think I can start. So just very quickly, I think what's important for us is that we understand the evolving landscape in prostate cancer, what might be just ADT a couple years back, what just might be ADT and docetaxel per charted years ago might no longer be the best answer at this point. So I think what's important is that we strive to continue to make these treatment options available for our patients, whether we are in a developed or like in our setting, a developing country. I think there's always that understanding the data, and really thankful about listening to Professor Fizazi here, understanding the evolving data of management of prostate cancer. And I guess as clinicians taking care of patients with prostate cancer, having these drugs available, thankful for more affordable drugs, more accessible drugs for our countrymen. And I guess that's something that we look forward to, better quality of life, better survival for our patients. Thank you, Dr. Jeff.
Thank you, Arthur, for that short message. Dr. Rizal?
Yes, I think that's the combination therapy in the cancer now is become, it's become more standard, especially in prostate cancer. And of course, it's similar that if we can get more affordable treatment, and of course, we can give more better service to the patient. But of course, there are many questions like, should we start directly for the combination like that, and or how we select, and also to select which combination is better, and also what is the sequence? There is still a lot of question for that. And of course, with this kind of meeting, like already Professor Fizazi mentioned, that I think they have become more clearly how we can give better treatment for the prostate cancer patient.
Thank you. Last word, Professor Fizazi.
Well, I mean, difficult for me to add anything. I fully agree with my two colleagues, really. And I think it's really actually much more important that they give you their perspective instead of me coming from France in a different setting. So I'm just glad I've heard what you said, and I actually totally agree. The great thing for patients is that intensification makes sense. It's great that abiraterone is becoming generic, also for more patients to benefit worldwide. And I really hope and I really think that we will see even more progresses in the coming years as we saw in the last decade. So this is just great.
Okay, so thank you very, very much. On behalf of Hetero, of course, we would like to thank all of you for those valuable insights and for the service that you do for our patients. Good evening, and to all the participants, thank you also for attending and for listening. Good night.
Thank you very much. Bye-bye.
Thank you.